Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us this morning. Before we begin, I'd like to thank our sponsors, Altman Health Systems, Studio Arts and Glass, and Genuine Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. Ryan Drake, who was with us quite a while ago in the WHVDC studio. And Dr. Ryan Drake is a neurologist at Neurocare Center and principal investigator at Neuroscience Research Center. Dr. Drake is board certified in neurology, neuromuscular medicine, and electrodiagnostic medicine. Good morning, Dr. Drake, and welcome back to the show.
Good morning, and thanks for having me. It's been a little while. I think the last time I was on, I talked about Botox and chemodenervation, and it was fun to kind of be in the studio. It's not as exciting here in my office, but that's okay.
All right. Well, I'll tell you what, they wouldn't let us in there for a long time because of Corona, and so Brad worked the system out. So we've been here since then. So
that's fine.
We think it works out okay. So.
I think so.
Yeah.
All right. Well, dementia is a general term for memory loss and other cognitive abilities serious enough to interfere with daily life. Alzheimer's disease accounts for 60 to 80% of dementia cases, and today more than 6 million Americans are living with Alzheimer's disease. Alzheimer's kills more than breast cancer and prostate cancer patients combined, with deaths from Alzheimer's increasing 145% since the year 2000. While Alzheimer's is a familiar term, more than 80% of Americans know little or are not familiar with mild cognitive impairment, which can be an early stage of Alzheimer's. Early intervention is critical, so it's important that we learn how to recognize signs and symptoms that we should bring to our doctor's attention. This morning, we're going to talk with Dr. Drake and learn about the risk factors for Alzheimer's, along with diagnosis and treatment. We'd like to remind our listeners that our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe.
Okay, Doctor, welcome. As I said before, you've been on the show before, but it's been quite a while back, and we're very happy to have you back. Welcome back again to the show again. Please introduce yourself and tell our listeners a little bit about yourself and your practice.
Sure. Thanks for having me. I'm a general neurologist in town. I work at Neurocare. I'm also a principal investigator within our research arm, Neuroscience Research Center. I grew up in Salem, Ohio, so not too far from here. My wife, who's Dr. Jennifer Drake, who has an expertise in epilepsy and sleep disorders, is also with us at Neurocare. And so we've been in town for 15 years, the entire time at Neurocare. And so it's just been really nice to take care of patients within Stark County and really many surrounding counties.
So where did you receive your training? And not in Salem, Ohio, certainly.
No. So I did my neurology training in Richmond, Virginia at Virginia Commonwealth University. And that's a 4-year program. We do the first year of mostly internal medicine and 3 years of neurology. And then I did a optional fellowship year at Duke University, where I did more nerve and muscle disease.
Interesting. So how long have you been a practicing neurologist?
I've been here for nearly 15 years. It's amazing how time flies, but it's been fun. I think one thing that we'll talk about here in a little bit when we chat about Alzheimer's is, when I first started there were many diseases that did not have a lot of treatment, or really not any good treatments. And we've seen that shift a bit, still not where we want to be in many disease states, but I now have a lot more tools to help manage patients than I did when I started.
Okay, tell us about your practice and what all you do.
Sure. As I mentioned, I'm at Neurocare. We're the only neurology group in Stark County, and we see patients, probably as far as an hour and a half east and west, and 2 hours south of Canton, a fairly big catchment of patients. Most of what we do is outpatient neurology, seeing patients in our office. That's about 85% of what we do, but we also do inpatient neurology, both at Cleveland Clinic Mercy and at Altman Hospital, where we're seeing acutely ill patients who are having strokes and ongoing seizures, as an example. The group of us, there's 5 neurologists, and I'll do a little bit of a dad brag about my partners. I always say how well trained they are. If you look at the 5 of us, we've either trained at Duke, at Mayo Clinic, or Harvard. And so we've been fortunate to bring that knowledge back to the area, and it's a really good practice. We have a physiatrist, a rehab physician, Dr. Natzinger, and then we have 7 advanced practice providers in our group, physician assistants and nurse practitioners, who also we collaborate with to help take care of our patients. And that's our day-to-day. We do a lot of sleep disorders. We have a sleep clinic and an in-lab sleep center where we diagnose sleep disorders such as sleep apnea. So it's a nice size group, and at this point, it's family.
Where are your offices, Doctor?
So we have an office. Our main hub is in Canton on Dressler. That's also where the research center is as well. And then we have an office in Alliance and an office in Oroville. Those are our 2 satellite offices.
And your sleep apnea facility, is that with your office, or?
Yes, it's in our building here, where patients come and do an overnight study with our sleep techs to help sort out what type of sleep disorder. Sometimes it's not obstructive sleep apnea, and it's an alternative, a primary sleep disorder. And then they will often follow up with, we have 3 of the neurologists are board certified in sleep medicine, so they will see that. So even my patients who have sleep disorders, I say I have 3 experts here in the building. So I will often have my patients see one of them just for a sleep consultation.
It's hard for me to imagine that people have difficulty sleeping. I really, about 11 o'clock at night, man, boom, I'm out. So amazing.
Yeah, it's nice. I mean, there are people, and myself included, that don't have any problems sleeping, but there's a lot of patients who have insomnia, problems falling asleep, waking up in the middle of the night. And then the big one is undiagnosed sleep apnea. Used to just think it's a snoring problem or a tiredness problem, but it's really a systemic disease. It contributes negatively to memory. It accelerates hardening of the arteries in our heart and our brain, and so that's why we're very aggressive in trying to diagnose and treat OSA, or obstructive sleep apnea.
Wow, it's just amazing.
Doctor, you mentioned a number of different patient types that you see. Are there any other patient types you want to bring up?
I think that my only comment is the number 1 diagnosis that we see in our office is migraine. There's about 40 million Americans who have migraine, and so we see a lot of migraine. That's probably about 15 to 20% of our day.
Okay.
Amazing.
So, all right. So you're also involved in research at Neurocare. Can you share with the public what that's like? Yeah,
so from a research standpoint, we are involved in clinical trials, and this is when a pharmaceutical company has some type of compound or drug, and it's been studied in animal models, and then it's felt to be safe for human trials. And initially, if we talk about clinical trials, there's 4 phases. There's phase 1, 2, 3, and 4. Phase 1 is typically healthy volunteers. they're given some dose, sometimes high doses of the medicine, of which it's safety data only. Phase 2 and phase 3 trials are trying to gather more safety data, but also efficacy data, how well the drug works. And more often than not, you need 2 phase 3 trials to be positive for that drug to go to the FDA to be reviewed and approved, so that we can have access to the drug for all physicians or other providers to write. And so what we are is we're one of the sites where we recruit patients for various trials, really across the neurologic spectrum. And I really felt it was important to continue and really ramp up our trial department, because, as I mentioned, when I started 15 years ago, lots of neurologic diseases that didn't have any treatments, don't have good treatments, that still exists today. There are many disease states that don't have good treatment options for patients. And so bringing these trials in allow patients to be enrolled if they want to. Again, we talk with patients about it's not a guarantee that it's going to work. All good trials, patients are either given the drug or a placebo. So not everyone is guaranteed to even get that drug, at least in the first part of a trial. But if you don't have trials in Canton or Northeast Ohio, then patients are having to travel to Pittsburgh or Cleveland or Columbus. It's just not feasible.
Interesting. How about we take our first break here, Doctor? You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters. It's not too late to get a flu shot. Stop in any medicine pharmacy today, no appointment necessary. We look forward to helping you stay healthy.
So, Doctor, how long have you been doing research in the community?
We've been doing research my entire 15 years that I've been here. I did research when I was a resident as a sub-investigator, and that's not the principal investigator. When you're a principal investigator, you're responsible for everything at that site. When you're a sub-investigator, you may be responsible for certain scales, such as a timed walking test that's required, or a certain memory scale. And then when I started at Neurocare, one of the physicians was running the research department, entering retirement, and I kind of took that over and have escalated that up over the last 5 or 6 years.
It must be quite an undertaking to be part of that. I can only imagine the record keeping and the restrictions and the protocols you have to follow. How does a patient get involved with the trial? Can you talk about that process a little bit?
Yeah, most of our trials of which patients are enrolled come from our practice. So we talk with patients. Let's say they come in for an evaluation for Alzheimer's, as an example, and there's not any, and we'll talk about that maybe a little bit later, there haven't been any disease modifying therapy for pre-Alzheimer's or Alzheimer's. And we'll talk about offering patients the enrollment in a trial versus some non-medication management of Alzheimer's. And so if patients have interest, then they go upstairs to our research department and often are given pamphlets or information, consents for trials, and then that's how patients are enrolled from our practice. Now, we often have patients who are calling in from the community to our research department, and then they come in for a quick screening visit regarding their memory. We often have to get notes or charts from their primary care or maybe other neurologists in an hour radius or 2 hour radius. So it's either patients calling in, primary care referring because they know about our trials, but most of it is us sitting down with our patients, and that's just part of the education piece that we provide.
Very interesting. What are you're involved, I'm sure, right now in clinical trials? What are they? What sort of issues are you dealing with?
Yeah, the majority of the trials that we're in right now, probably 50% at least, are within the realm of Alzheimer's. And
Mm.
when you talk about Alzheimer's, historically you had Alzheimer's, and the only medications that we've had are what we call symptomatic medications, like Aricept or Namenda, known as donepezil or memantine. These medicines don't do anything for the disease itself. They essentially allow the nerves in our brain to talk better. But as time goes on in Alzheimer's, these nerves are degrading, and these medicines don't repair these nerves or stop the process. So the majority of newer clinical trials are disease modifying. They're trying to go after what's creating this nerve breakdown. So as far as Alzheimer's, it's amyloid plaques that they're trying to go and attack. And so not only are we doing trials for Alzheimer's, but we're also doing trials for some people call pre-Alzheimer's, which is MCI, mild cognitive impairment. In the past, we used to think, oh, mom or grandma, she's forgetful, that's just her age. But what we're learning is short-term memory problems that are a change from the past, that interfere maybe a little bit with life. That's actually a clue that someone's developing Alzheimer's or mild cognitive impairment. And so we're doing trials not only in Alzheimer's, but a lot in MCI, mild cognitive impairment. And then interestingly, we're also doing it in preclinical Alzheimer's. So these are patients who they don't even have MCI, they have no cognitive issues, but they have strong risk factors for the development of Alzheimer's, including maybe family history. And so these medications are being given to those patients because in the end, we think that if we treat Alzheimer's or pre-Alzheimer's or pre-Alzheimer's very early, that's the best chance that we have. So most of our trials are within the Alzheimer's realm. We currently have other trials for essential tremor, which is the most common tremor in the world. There's not an FDA-approved medication for essential tremor, so we see a lot of that. We have trials for migraine. We have trials for multiple sclerosis, which is an autoimmune disease of the brain and spinal cord. And then we have trials for myasthenia gravis, which is an autoimmune disease of our peripheral nervous system, our nerve muscle highway. But I think our biggest interest right now is within neurodegenerative diseases. Fancy way for saying our brains break down faster than they should, and they cause problems. The most common neurodegenerative disease in the world is Alzheimer's. And number two, the second most common neurodegenerative disease is Parkinson's. So the focus, I think, is Alzheimer's, Parkinson's. There's another type of dementia that's neurodegenerative as well called Lewy body dementia. And the hope is that we will find treatments to either delay onset or slow the progression.
So how's Alzheimer's disease different from dementia?
That's a really good question. Dementia is the umbrella term. And so dementia is when patients have typically short-term memory problems. Another part of the brain is not working, like we call executive function, our ability to follow certain steps, point A, point B, point C, issues with attention, concentration, judgment, issues with language, getting our words out, understanding what people are saying, issues with visual spatial, so our ability to navigate with driving. So dementia is memory problems. One other of those issues that's progressive and interfering with our daily activities. That's how we define dementia. But going back, dementia is an umbrella term of which there are subtypes of dementia. The most common subtype of dementia is Alzheimer's. And that accounts for about 70% of all of the dementias. There are other types of dementia like Lewy body dementia, Parkinson's dementia, frontotemporal dementia, vascular dementia, and others. But I think there's a negative stigma with using the term Alzheimer's, and you have patients who sometimes are referred to me for evaluation of their memory, and they say mom has dementia. You go through the history and exam, you come to the conclusion that it best fits the picture of Alzheimer's, and then it's kind of an eye-opening experience. Oh my goodness, mom has Alzheimer's. I thought she just had dementia, when really it's a subtype of dementia. And so if we know someone who has dementia, odds are it's likely Alzheimer's. And I think that's a little bit why I'm here today, not only to talk about Alzheimer's and our clinical trials, but really get the word out that it's okay to use the term Alzheimer's. I think we have to reduce this negative stigma with the term Alzheimer's and start to talk about it earlier, because I think what's going to happen over time is that we need to talk about Alzheimer's when we're 40 years old or 50 years old, not waiting till we're in our 70s. But again, dementia is the umbrella term. Alzheimer's is the most common subtype.
Wow. It's very complicated explanation of all of this. You know, it seems that we're making progress in these diseases. Is that true? I know we can't rebuild the brain, okay? Once this thing happens. What do you think?
Yeah, so why does Alzheimer's occur? There's a protein in the brain called amyloid, and essentially it starts clumping together, and it forms these clumps called amyloid plaques. And these plaques then act as roadblocks within our nerve highway. And so as time goes on, more and more roadblocks get laid down. The exit ramps start getting closed. And then in addition to the amyloid plaques, which are being created 10 to 20 years prior to the development of clinical symptoms, in addition to amyloid plaques, there's another protein called tau that's blocking highways more within the nerve. And so you have accumulation of amyloid and tau, these proteins. And so that's been the main theory of why does Alzheimer's occur. We don't really know what stimulates these abnormal proteins. That's the problem here. But all of the medicines that are being looked at, and we've had a little bit of breakthrough within the last year or two, are designed to go out and bind to the amyloid and then try to clear it from our brain. And so that's where most of these targets are. They're trying to target the amyloid protein. They're trying to target the tau protein, or sometimes they're trying to target where, if you think about like a bunch of grapes, so there might not be targeting the grapes, but the stem between the grapes. So they're trying to target the sticky substances. And I think that's where we are now. And we've had some breakthrough in what we call disease modifying therapy, not the symptomatic therapy, but this is what I referred to earlier as disease modifying. Go after what's causing the problem. There's essentially 4 drugs that have either gone to FDA or in the process of going to FDA, and essentially 2 of the 4 have not been favorable trials. One was just approved on the 6th of this month, but I don't know if we're going to have access to it because there are restrictions by Medicare in paying it for it. And these are unfortunately not the answer. Are they clearing amyloid in our brain? Yes, but the improvements of patients' memory is not overly robust. And so that's why I think over the next 10 years, 5 to 10 years, the clinical trial space will still be a really important space to try to find something that works even better.
Okay, doctor, I'm late for the break.
Okay, sorry.
It's all right. I wanted to hear that. It's the bottom of the hour, time for the news. Thanks for joining us this morning on Health. We are back. This morning, Brad and I are talking with Dr. Ryan Drake, neurologist at Neurocare Center and principal investigator for Neuroscience Research Center. We have a lot more to cover this morning, so let's get back to the show.
Okay, doctor, before the break, you talked about what causes Alzheimer's disease. I wondered if you could touch on what stages there are, and if we know, clearly you said we don't know why those plaques can occur, but I'm wondering, do we have any genetic or environmental links that you can touch on too?
Sure. So when it comes to stages of Alzheimer's, we typically talk about there's a mild, moderate, and severe stage of Alzheimer's. Mild is when patients are having problems with managing their checkbook, managing their medications, maybe getting lost in unfamiliar places with driving. Moderate is patients are really unable to manage their meds, their finances, they're not able to drive, they're not able to cook. And severe is when patients are quite bad. They're often having significant language problems, issues with talking, walking, and a lot of these patients required 24-hour, not just care, but nursing care. And as I alluded to earlier, that we now know of MCI, mild cognitive impairment, which is a pre-dementia state, and then even pre-clinical Alzheimer's, which is when we have risk factors for Alzheimer's, but have normal memory. And so there is a genetic risk. When you talk about early onset dementia, which unfortunately is less than 65 years of age, we unfortunately see patients who are in their 40s or 50s who are diagnosed with Alzheimer's. 1% of all of Alzheimer's is due to these three genes that create Alzheimer's. And if mom or dad, you just need one parent that has it, each child has a 50% risk of getting that gene. If you get that gene, you're guaranteed to get Alzheimer's. But that's only 1% of all of Alzheimer's. So we also know that families can cluster and have some family members with Alzheimer's, but it's not lots and lots of family members. So there's probably some genetic risk, and it's probably multifactorial, or what we call polygenic. The most common genetic risk factor is something called apolipoprotein, or ApoE. And we get one ApoE from mom and we get one from dad. And you can either get a 2, a 3, or a 4. So most commonly in the United States, people are 3 3s, and that's a neutral risk. But if you're a 3 4, so you have one copy of a 4, that increases your risk versus a general population by about 2-fold. And if you're a 4 4, that's really rare. It's about 2% of the US population. That increases your risk by about 10 times. And so if you heard Chris Hemsworth, Thor, the actor, he was in a show in Disney Plus called Limitless, and it's talking about longevity. And unfortunately, spoiler alert, if you haven't seen it, he was told that he is a 4-4, unfortunately. And so when they talk about in that series that he has a rare genetic risk factor for Alzheimer's, they're talking about the ApoE gene 4-4. What we know about the ApoE gene, it's a risk factor gene. So it's not you're going to get Alzheimer's no matter what, where that 1% of that I talked about earlier, you're guaranteed. So just because you have a 4 or a 4-4, it doesn't mean you're going to get it. There's about 30 other risk factor genes that probably play a role here in either interacting with ApoE4 or creating other risks. There are patients who in lots of cohorts are 4-4 and never get Alzheimer's. So they probably have some gene that decreases that risk in some way. What are the other what we call risk factors for Alzheimer's? We talk about non-modifiable and modifiable. So non-modifiable are you can't do anything about it, and that's your genetic risk. The number one non-modifiable risk is your age. So your risk of Alzheimer's at 65 years old doubles about every 5 years. Female gender, unfortunately is about twice as likely as male. That's being heavily researched, felt probably hormonal in nature. And then you have your modifiable risk. And your modifiable risks are all the things that we can do every day. There's research that shows if everyone in the US participated in their modifiable risk, we could eliminate 40% of Alzheimer's. So if you look at Alzheimer's, about 6 to 6.5 million US people have Alzheimer's, as opposed to Parkinson's, it's 1 million to 1.5 million. So you could essentially eliminate over 2 million cases of Alzheimer's if we did our modifiable risk factors. So what are our modifiable risk factors? That is our vascular risk. So diabetes, lipids, hypertension. So really being aggressive in management of those vascular risk factors, working with your primary care to keep those in check. Those are pretty huge. Exercise is the #1 modifiable risk factor for Alzheimer's. And so if you're not exercising, then you should be. And it's not just going on a walk, unfortunately. It's exercise, typically aerobic exercise, that you're moving, you're getting your heart rate up, and it's getting your heart rate up and sustaining that for a 30-minute period of exercise. And ideally, it should be 5 to 6 days a week. As long as your primary care doctor, your cardiologist says you can do that, then you do it. Exercise is really important. Sleep is ultra important. We know that if your sleep is not regulated properly or you have undiagnosed sleep apnea, it really plays a role. Our diet or our nutrition is a huge risk factor as well. We know the Mediterranean diet reduces our risk of Alzheimer's. So I encourage listeners to go out and Google Mediterranean diet if they're really interested in not only their cardiovascular health, but their brain health. Other modifiable risk factors include learning as much as you can early in your life. So your degree of education plays a role. It's probably building up a cognitive, what we call cognitive reserve, and then learning new things in middle ages is also really important. So those are, we talk about how are we going, although I'm here to talk about our clinical trials and our treatment and the new science, I don't want to treat you in my office. I want to not have to see you. And I think if the US population starts paying attention to these and being aggressive, we can probably delay or eliminate a fair amount of Alzheimer's.
The whole program's been amazing. And I can't help but think, we got to take our last break here, but sure. I cannot help but think I don't understand why we are not genetically testing every patient that goes in to see their primary care to identify some of these things. I mean, I paid for all those tests, so I've got all the data you just mentioned, but it just seems like we could be so much more preventative and proactive if we acted on at least our genetic base than just finding out when it happens. But I digress, and that's another program. So,
okay.
Okay, final breaks here. You're listening to Health Matters with the Medicine Center Pharmacy. Thanks for joining us today. You're in our last segment of our show, and it's very, very interesting.
Doctor, do you have anything else you want to add about diagnosing Alzheimer's or other memory disorders?
Yeah, I think to understand a little bit, when patients come for an evaluation of memory, we take a fairly in-depth history and ideally with we call corroborating historians. So a spouse or an adult child who can help us define this timeline. And so we're looking for issues with managing meds and finances or having problems with repeating ourselves. That's part of the history. We do an exam where we're doing a neurologic exam to make sure there's not any signs of Parkinson's or Lewy body, which can be other types of dementia. We're doing a bedside memory examination to try to figure out what parts of the brain are not working properly. And then we do testing. We always do an MRI of the patient's brain. And the thing that I like to have patients understand, or family members, is we're not doing an MRI to diagnose Alzheimer's. We're doing an MRI to look for other conditions that could mimic Alzheimer's, like a brain tumor, like increased fluid-filled spaces of the brain, something called normal pressure hydrocephalus, looking for silent strokes that unfortunately can happen over one's lifetime. So MRI of the brain, we often do cognitive or memory labs that include B12 and thyroid disease and folic acid. That's kind of the standard workup. There are some patients who maybe have uncontrolled mental health disorders, really bad depression, anxiety, that can affect memory. And so sometimes we are doing specialized testing called neurocognitive testing.